I'm Christine Mallinson. I'm the director for the Center for Social Science Scholarship, which coordinates our annual Social Sciences Forum lecture series. This is our first Social Sciences Forum Distinguished Lecture of the spring semester, and it is also the Distinguished Lecture in Psychology, and I want to thank the department for arranging this talk today. Before we begin, I just want to take a brief moment to mention our next event at 4 p.m. on Thursday, March 4th. Dr. Jennifer Nash of Duke University will be giving a talk called In the Room, Women of Color Doulas in a State of Emergency. You can find more information on our website, socialscience.umbc.edu. And I'd also like to invite you to engage with us on social media. We're on Facebook and Twitter at UMBC SocSci and on Instagram at cs3.umbc. Just a couple of housekeeping details. Attendees are all muted with video off for this lecture, but we do welcome your comments and questions at any point. Just put those into the Q&A box. Our panelists will receive those and will pose the questions to our speaker after the conclusion of the lecture. Thank you all again so much for being here today, and I will go ahead and turn things over to Dr. Ann Brodsky, who is the chair of the Department of Psychology.
Thanks, Christine. Hello, everyone. Thank you for being here. I'm so sorry that we can't see you all in person and you can't be here in the same room with our distinguished speaker, but we're really pleased to have you here and particularly pleased to welcome Dr. Gail Wyatt. Dr. Wyatt's a clinical psychologist, sex therapist, and professor in the Department of Psychiatry and Biobehavioral Sciences at UCLA. She received her BA and MA from Fisk University and her PhD from UCLA. She was the first African-American woman to be licensed as a psychologist in the state of California, first African-American woman to be a full professor at UCLA School of Medicine. And I believe she also has a Baltimore connection, having worked as a school psychologist here in her early career. Her research examines the consensual and abusive sexual relationships of women and men, the effects of these experiences on their psychological well-being, and the cultural context of risks for sexually transmitted diseases and HIV. She's conducted national and international research since the 80s and has been continuously funded by the NIMH, NIDA, state, and private foundations. She's a recipient of numerous awards. She has more than 250 journal articles and book chapters in her name, has co-edited or written 6 books, including Stolen Women, Reclaiming Our Sexuality, Taking Back Our Lives, and No More Clueless Sex, 10 Secrets to a Sex Life That Works for Both of You. Dr. Wyatt's an assistant director of the UCLA AIDS Institute and coordinates a corps of behavioral scientists who consult with other researchers to recruit underserved populations and conduct research that effectively incorporates sociocultural factors into HIV/AIDS research. She also offers workshops on creating emergence investigations from underserved populations in academic settings. As if this isn't enough, we don't know how she fits this all into her life. She's also, not surprisingly, received numerous awards and honors for her scientific accomplishments, her mentoring and teaching. And she's testified before the United States Congress 8 times on issues related to health policy. So with all of that, that gives you some introduction. And we're really looking forward to hearing what you have to share with us today, Dr. Wyatt. So thank you so much for being with us, and I will turn it over to you.
Oh, thank you so much, Anne. It's such a pleasure to be here. I too apologize that I'm not there in person. It would be so much more vibrant and alive if we could all just relate to each other. So I hope we'll all stay where we are for a little bit longer, and hopefully maybe this time next year, everyone will come to Los Angeles, or I will come to Baltimore, where we have lived for 18 months. It was an experience within itself, but I learned a lot about living in Baltimore and the really rich history that it has, and also the kindness of some of the people, since we didn't know anybody and had a tiny son. So that was the beginning of both my husband's and my careers in Baltimore. So I've got some good vibes. There are some others, you can hear the hesitancy in my voice because Baltimore was not all good, but it's certainly better than it was in those days. So I'd like to start, and I think Amy is going to advance my slides for me so I can just focus on what I want to share with you. I'm so excited to have this opportunity. There are many, many things that I'm doing at UCLA, and I welcome you to ask me about them. Everything that I know I'm going to say won't be agreed to by everyone, and that's quite all right. Part of the issue, I guess, of inviting different people is to hear different perspectives. What you'll hear from me is my experience growing up in a segregated America and now dealing with white supremacy in the world in which I live today. I do want to say that I do international work in South Africa. I have done so for the last 16 years, and that has given me an acute appreciation for what it must have been like in the early years of this country and trying to establish a society, and one that is multi-ethnic, diverse, multilingual, and has a history of oppression, severe oppression. And that's really part of what brings me to this particular topic today. I want to, next slide, please. I want to be able to acknowledge some of the things that keep me going. And when I want to talk about the present, which I will be doing in the research that I hope to present to you, much of which I've done, most of which I've done, I like to begin with this African proverb. You can't know where you're going until you know where you've been. And I think that for America and for the world and for this particular time in society, we have to know where we have come from and where we've gotten some of the ideas and notions and concepts around health, or who deserves to be healthy, or who's expendable, that have really a deeply embedded history in our society. So next slide, please. So I think this is really the text of my talk. I also want to acknowledge many, many other representations of the whole idea of reaching back. I think it's very appropriate in Black History Month, but it's also appropriate every day, particularly because we have so many individuals who need help today, more than ever it seems, that the whole idea of Sankofa, which is reaching back to get it, to get someone, is very, very relevant. And if you don't remember anything else that I share with you, this is so important, is that we don't just focus on ourselves, but we focus on the context of our lives and those in most need. Next slide, please. So I want to thank many people. I want to thank Steve and Christine. I hope you don't mind me calling you by your first names, but I feel more comfortable talking to people the way I usually talk to people, and I don't address their degrees. I find that in the community, no one really cares what degree you have. It's who you are, how warm and authentic you are. And I found that Steve and Christine have been very kind to me, but so has Amy Barnes, Ann Brodsky, who introduced me, Danielle Beatty Moody, who I could not place in terms of having actually met her, but she recommended me for this talk today. And so I don't know that I'll get a chance to meet her soon, but one of these days, Danielle, we are going to cross paths, and I'm going to give you a hug for thinking of me and thinking of my work. Next slide, please. So that means anyone who thinks of me is definitely going to be thanked in a warm way. I want to begin with the title of my talk, which is All They Want to Do is Get in Your Pants. This is something that my very beautiful and talented and well-educated mother told me when my sister and I were growing up and were curious about little boys. So it was something that stuck with me. My sister has passed, as my mother has, and dad, so I'm the only survivor of my nuclear family. But we used to laugh at when we remembered some of the things that we were told by our parents about sex, about sexuality, about relationships. And this one in particular just really intrigued me, because I just wondered what was so terrible about boys that they had such only one thing on their minds. And I wanted to know where all that came from. So next slide, please. But I want to remember my mom and my dad during Black History Month in particular, because they were both teachers. They were both third generation college graduates. We lived a very different life from the stereotypic life that you usually see about Black people. So I hope that in my talk and talking about my background and also answering questions, you get a sense that we have this unidimensional perception of Black people that is so wrong. And it gives you the sense that nobody has anything and nobody knows anything, and they have no abilities and no skills. And that really is, I think, part of the basis of why people feel that they're better than a lot of Black people, and why people feel that if they're not infected with transmitted diseases, that they're somehow better. These kinds of things could happen to anybody. And of course, because I do like to study about human sexuality and had to find a federal arm of the government that will allow me to ask questions about sex, I was really limited. So I found HIV and AIDS as an area, and I've been funded by HIV and AIDS grants since 1980. I got my very first K. I don't know if Ann shared with you that I'm the first African American or person of color to receive a K award. And that's a whole story within itself. The experience of getting one and being told that it wasn't for me. But at any rate, I did. And my very first grant was an RO1, both by NIMH. And that started me on my journey of studying about African American women, human sexuality, sexual experiences, psychosexual experiences, much of which I'll share with you today. So I just want to start off very briefly with this old, tired slide that talks about AIDS being the cause of death among cis and transgender African American women ages 24 to 34, and the third cause of death for ages 45 to 54. It's almost like you can't escape death by HIV and AIDS among African American women. But the thing that's most disturbing about these statistics is they've been this high for almost 40 years. And there hasn't been anything really effective that's been funded and promoted in community health centers in our country for people of color that's really made a significant impact on their behavior. So while the money is being placed on intriguing ways of administering the most elegant of medications, if we don't find a way to talk and relate to people and help them to understand what health is and their need to be a part of the healthcare system after so many years of not being a part, those medicines are not going to be taken advantage of by a significant portion of our population and world. So I want to start with that reality check. Next slide, please. So in my studies, I have spent a lot of time, because I attended Fisk University, a little college in Nashville, Tennessee. Only 1,200 people were at that college, but it was the best experience for me. It was historically Black and very, very activist. And so I met all of the leaders in the community, in the world, who came to Fisk to lecture to us and to activate us. I was 16 years old when I went to college, and I began to read about slavery because I was intrigued and just could not make any sense of what I learned in the public school system. And so over the years of my career and growing up, these were the 7 areas that I really felt were most impacted by the 401 years of slavery and oppression that have occurred in the United States, as well as even more of a huge period of time in South Africa. So I've got a composite of a national and international model that I'm working on in a book right now. And I want to start with sharing with you some of the effects of these experiences. So next slide, please. The first is mental health. I've pictured some of the experiences just so you can get a sense of the severity of oppression, terror, trauma, and control that was a part of the history of this country that we all love so much. But mental health was thought to be something that was sacrificed if a person wanted to escape or leave or didn't want to work or or to be owned by anyone. And if they became depressed or if they had mental health problems, it was considered to be a weakness in that individual. So if people had those kinds of thoughts of wanting to leave or not wanting to be owned, they were encouraged to keep quiet so that they wouldn't be sold away to someone as a punishment for those thoughts. But what comes out of that some 400 or more years later is that there are many individuals who have an exaggerated fear of being alone, an exaggerated sense of loss, anxiety, and fear of the unknown. Now, as we go through these 7 areas that have been affected, I just want you to think about what's going on today in our society so you can see how some of the roots of oppression have an impact on COVID and on the adjustment of our society to deal with or to deny that these problems ever existed, not only during slavery, but now that they don't exist. Mental health problems are very much a point of confusion today for many people. Next slide, please. The second area is communication skills. The roots come from the inability to speak unless you were given permission, or to look at a person unless you were given permission. You certainly know probably now that people could not marry unless they had permission from the individuals who owned them. So the fact that people could not communicate with each other in normal fashion, of course, gave roots to having difficulty in being able to balance speaking and looking at people at the same time, yelling when maybe there's no need to yell, or being too soft in tone when there's a need to speak loudly. So there's that whole regulation, deregulation, that sometimes isn't learned in many homes because, you know, we're only 4 generations out of the kind of systematic oppression that I'm describing to you from days of slavery, and then answering and acting in a timely manner so that things get done on a Western principle, which means you get things done right away, regardless of being well or wanting to do things, versus doing things in a manner where you finish them when you want to finish them. Next slide, please. The third area that was affected was body awareness. And I've spent almost my entire career looking at how people define who they are by their bodies, and what happens to their bodies in the process that really can serve as a template for all kinds of psychological problems in children, adolescents, and in adulthood. This was a poster that I saw in Missouri when I was speaking in St. Louis. The most dangerous place for an African American is in the womb. Missouri at that time, they probably still are, was very pro-life. And this was a poster discouraging termination of pregnancies. So the lack of body awareness comes from, of course, being owned. Someone owning you, being able to rape you. In fact, there was no statute on the books for the federal government against an African descendant woman being raped by anyone, Black or white man. So that the whole idea that if you did not own your own body, anyone could take control of it. And that has had some really significant effects on poor health care and the reluctance to seek care, not really knowing if you really will receive care. Let me give you an example of what a woman told me in an interview, a qualitative interview. And that is that she was 12 years old and had some kind of pelvic pain. And her mother took her to a doctor, obstetrician gynecologist, who used an adult speculum on her. Now, she was a child, and he asked her if she'd ever had sex before, anyone had put a penis in her vagina. And she said, "Oh, no, sir." And he used an adult speculum. Now, all the women in the audience probably are flinching because this was a child. She had the body of a child, and she never had anything entering her body cavity. And yet he used an adult speculum, which is much bigger, broader, and really opens the body a lot more. The assumption is that you couldn't possibly be telling the truth about not having had sex at age 12, because many girls at that age are considered to be promiscuous. So that is one of the symptoms of not having control and not learning enough about the body, the parts of the body. But also on the other end of the spectrum is a distortion of what the size of the body really is, that people might misinterpret or interpret body size in a very different way. Coming from an ancestry that involved Africa, women are much larger in size, much bigger boned in that part of the world than some of them are here, and which leads to a different perception of what is healthy, what is even considered to be an adult body. So you get a sort of a one end of the continuum or the other in terms of how people might consider body awareness, body health, and the responsibility for it, and what they need to do with it. Next slide, please. Dysregulation of emotions is really what I've been talking about all along. The historical roots on severe punishment and torture as a consequence for not working or being ill, speaking out, and the inability to cry, to express anger, pain, or loss. These were all signs of weakness again. So out of that root comes trusting no one, or really putting people to the task when a person tries to meet an individual for the first time. That's what I call healthy paranoia, because some people really do need to wait until they meet someone and have some reason to trust, rather than just trusting blindly and meeting a stranger. And then trusting with insufficient criteria for a person to be trusted. That's the other end of the continuum, which means people are given trust without having any knowledge of that person. This is a very popular illustration of a man who was a slave and who was beaten and flogged, and these are welts on his back. Next slide, please. This is another very popular myth about African Americans, particularly, well, men and women really, but in different ways. It's the John Henry syndrome. It's based on expectations of strength and inhuman abilities. The ability to work for long periods of time probably evolved from working in the fields during slavery, or in factories when people came north. Women cooking, taking care of other people's children for long periods of time without breaks or lunch or anything of that type. But the John Henry syndrome is that this is expected because these are superhuman individuals. We see it today with athletes, that athletes who can exhibit superhuman abilities are very popular in our society. And some people don't realize that it emanates from sort of the John Henry era, where people were expected to be well built and to be able to do amazing athletic things. So sometimes as a result of that, people don't realize what is normal in terms of endurance. Maybe people work too long, don't take vacations, and then have a health consequence as a result of that, but because they have ignored their own physical limits. Next slide, please. And then finally, health consciousness. This is just something that's very conscious and very popular and very common today. It's based on marginal, if no healthcare except by a midwife, and a rejection of facts, because facts came from authorities who people did not believe. And this is coming back to haunt us in what we're experiencing today in COVID. Outcomes would be insufficient knowledge about how people get sick and how things are transmitted, a need for practical health and proactive health and maintenance and self-care, which has to be taught. And yet it's very frustrating to see these are concepts that are not taught in our schools, where children learn how to eat properly and in a healthy fashion, to care for themselves, to be able to take time outs. These are all things that could be easily promoted in the school system, and yet they are not, and it has really not been a universal concept that individuals have an opportunity to learn, and it has a consequence. Next slide, please. I said that was the next slide, but this is the last slide, interconnectedness. It has a lot to do with how people connect themselves with each other. This was particularly exaggerated during times of slavery because families were separated. So if an individual was able to find their family or to make a family of their own, they were really, really cherished because being able to be with someone and stay with someone was of value. I can't say that that's changed a great deal because there are at least 10 women, African-American women for one man in our society. And where are men? They're in prison or they're dead. So we don't have a balance. We don't have an opportunity for a balance of people. If you want a male or a female for a partner, many times there is a gender and a sex imbalance that makes it very difficult. But the ability to stay in a relationship is valued. And the saying, I am because we are, means that my identity is tied to the fact that we're in a relationship. So you can see how that can be positive for those people who have good relationships, but also extremely negative if a person is seeking a partner in the era of HIV, STIs, and COVID, and cannot connect with the right person. It may encourage risky behavior to the extent where people would allow themselves to be in situations looking for a relationship where perhaps all of the circumstances are not the best. Next slide, please. So what are the dynamics? What do we do with all of these 7 issues? And this is where my research started very early in my career, knowing about the history of the United States and going to school where we actually took courses in African-American history and African history and the African diaspora. I knew that sexual abuse of women and men was very common in the world and not very well studied. And so in my K award, I included questions that are included in the Wyatt Sex History Questionnaire. And you can get a copy of it if you like. All you have to do is email me. That deals with how to ask questions about all kinds of consensual and non-consensual sexual experiences before the age of 17, which is considered childhood, and 18 and above, which is considered adulthood. So the prevalence I found in my first studies was 1 in 3 women, and you'll see a little later 1 in 4 men. This was higher than anybody else reported and published on. This is in the first part of the 80s. And so nobody believed me. They thought this can't be true. This can't be correct. You're a young researcher. And there were all kinds of other things assigned to me because I was African-American that this could not possibly be right. But over the years, this has become more and more supported by everybody else's research that sexual abuse, and it has not changed. I've studied women in just out of World War II all the way to the present and found that the prevalence has not changed from 1 to 3. You wonder why sexual abuse has been accepted as something so common and so ordinary that our society has never done anything to address it. That's a whole talk within itself, isn't it? But I do want to stay on task because we'll have so much to share. Women, especially Black women, are likely not to tell anyone, not their mothers or the police. Why, you might ask? They were afraid of being blamed for the experience having occurred. Again, the stereotype of African-American girls being precocious, sexually precocious, came out of the assumption that Black women were promiscuous, had no borders or boundaries around their sexuality. This was certainly true of men, but certainly true of women as well. So the response of the society for a Black woman to report sexual abuse or the sexual abuse of her children met with a lot of questions and confusion, as well as a suspicion that probably this did not happen the way it was being told. So that shut down and continues to shut down a lot of individuals from reporting. And unfortunately, if sexual abuse happens before the age of 17, it is likely to happen again. So I made the point that women are sometimes blamed for their own abuse. We know that women are blamed for their own rapes, but this is not a new pattern. Next slide, please. Women who with sexual abuse histories are likely to have consensual intercourse earlier than women with no abuse histories. Now, this is a fascinating issue because when I early in my career was asked to talk about adolescent sexuality, teen pregnancy among Black girls, why did it occur? And the first thing I asked was, did anyone ever ask those girls? Not give me your age, your education, and this, but what happened to you? And when you asked young teens what happened to them, these are teens that were pregnant or who had had children, they talked about their sexual abuse. There is a connection between consensual experience and non-consensual. That is because the non-consensual occurring earlier in life set a template for girls to continue that pattern into their own consensual experiences. But no one had even asked the question. These were teen girls that were considered, again, to be promiscuous, to not have good parental supervision. Certainly the supervision could have been true, but the fact that, again, they were being blamed for their own pregnancy is a problem that we still suffer from. As recently as 5 years ago, when I was asked if I thought it would be a good idea, or maybe it was 10 years ago, if I thought it would be a good idea to have a reality show about teen pregnancies and what happened to girls. And I said, absolutely not. Guess what? That's one of the most watched programs on television today. Again, nobody paid attention to the fact that this just might model for young women the fact that having babies when you're teens is really okay. It creates an interesting story, and you can be on television and be a star, because some of those young women are continuing to be on television in different reality shows today. An interesting conundrum in terms of how and why is this not of concern in our society. So Black and white child sexual abuse survivors who are re-victimized, and this is that something happens to them again, tend to have a pattern of more unintended pregnancies, abortions, sexually transmitted infections, and to engage in high-risk sexual behaviors that are HIV related than women with only abuse history. So the re-victimization also has an effect. Next slide, please. Links to disease transmission was pointed out, I think, in the early 90s by my research team, where HIV positive women were 2.5 times more likely than HIV negative women to report child sexual abuse before 18. So if you've seen a couple of these slides, you begin to see a pattern of behaviors that are also associated with the trauma that comes through these abusive experiences. And we were able to report decreased condom use amongst this population of abused women, poor medication adherence, sexual and drug-related risk-taking behaviors, more sexual partners, sexually transmitted infections, and more severe histories of rape. All of these have been of concern as outcomes, but few people looked back to see the etiology of these experiences. And I was able to document in the early 90s histories of trauma, sexual trauma, but nobody believed me. So I'm thinking, okay, we're just going to keep writing, okay, and hope that this will take on, because this is of concern. The HIV interventions started being funded early in the 80s, at least the studies just including men, but the patterns are the same with men and women. And if you are a person of color, they're even more exaggerated. But it's been amazing to see how much money is being placed into interventions that deal with simply telling people you're at risk and you need to use this and that, and people wouldn't change behaviors. So, you know, it's taken American investigators a long time to be able to understand that something else about the abuse experience and the trauma of it perhaps needed to be addressed. Not just the need to learn how to use a condom, but the need to learn how to take care of oneself. Next slide, please. There's another huge factor that was overlooked in our healthcare system. It's racial discrimination. You would think, what? But this was not asked about, and I'm getting ahead of my story, but because discrimination was not asked in any of the interviews that we reviewed, interview protocols, we developed a trauma exposure risk index. It's called the LADS, developed at UCLA, of course, and it includes the cumulative experiences of discrimination, intimate partner violence, sexual abuse in childhood and adulthood, family adversity, that families fighting, and community violence, people having riots, killing one another, and being threatened with one's own death as a result of living in a certain community. Next slide, please. Now you might say, hey, those are some of the items that are included with ACEs. But ACEs did not include perceived discrimination. And we were not competing with ACEs at the time. We were simply looking at histories of trauma, because my Center for Culture, Trauma, and Mental Health Disparities includes very comprehensive interviews about the extent of trauma. And we get into asking specific questions about the whole experience, who did it, how many times. All of those things factor into what we call severity, which has a huge impact on a person's mental health. But here again, the trauma exposure risk was a new concept. And we found that it was associated with severity of depression and post-traumatic stress disorder, as well as somatic symptoms. Now, I focus on mental health issues that are kind of normative, things that happen every day, rather than major mental illnesses, and don't always use the DSM-5 to identify depression, PTSD, or somatic symptoms are just what they are, symptoms. Because most people of color don't get to a mental health professional for a diagnosis. And when they do, they're many times misdiagnosed because people don't understand what is culturally, those 7 principles that I told you about in the beginning, and where some of the behaviors may have come from. So they immediately link them to depression or PTSD for that matter, without understanding that these are symptoms that occur. And if we help people to manage them better, maybe if they never get to a mental health professional, they will engage in the kind of self-care that's needed. So we know that discrimination, I hope we know now that discrimination is a severe trauma and that it should be asked about. We have found that in asking about discrimination, racial discrimination, that women have health outcomes. And I think David Williams has also shown the same thing, that these are questions that are usually not asked. And yet when you do ask them, particularly women will talk about the fact that they stay out of the healthcare system. They don't like doctors, don't want to talk to doctors, prefer to talk to doctors of color when they do. But these are huge issues that we're grappling with today, because some of the folks that I bet are the same ones, if I could go back and find them, who reported racial discrimination incidents that were just horrendous, also are probably not as welcoming to the whole idea of getting a vaccine. So we have not really grasped, when we talk about discrepancies and disparities in vaccine access, we talk about the clinics not being in the community and that people have vaccine mistrust. Yeah, they sure do. But beyond that is a sense that people don't accept you as you are as a person and give you that respect that you need to feel welcomed in a healthcare system. And if we had that, if we'd ever had it, perhaps we wouldn't be dealing with the issues that we are today. So we know that testing is affected when women feel discriminated against in the general society. We also have studied Black women in HIV serodiscordant relationships. That's where you have a partner and either you or your partner is HIV positive and the other person is not. But in a serodiscordant relationship where you have support of a partner, Black women were less likely to get tested and feel unfairly treated. Next slide, please. So you see, these are not, I think, record-breaking findings. They weren't difficult to find. We simply asked different questions that were more relevant of the experience of people of color. So we also know that trauma, if I've made that point now, trauma in our society, and we talk about baseball, trauma is as common as baseball and apple pie. It's happened, it's been accepted. The traumatic experiences of children have been pretty common. The traumatic experiences of men and women, particularly African descendant, have existed all this time. We haven't even started talking about men, and I'm not going to spend as much time because there's less literature, and that's a part of the book that I'm working on right now. But this is something that as health professionals, and I hope that you're hearing me if you're in the audience, we have got to get a hold of, because we can affect healthcare utilization and adherence on people living with chronic diseases when we ask them the right questions and we know how to treat people and help them with the issues that they're really dealing with. So here again, people who have a history of trauma report that same pattern: inconsistent treatment adherence, treatment dropout, non-compliance, and experience in the medical care system as being intrusive and re-traumatizing. So talking to doctors, being rushed through in the 15-minute limit, next slide please, is only re-traumatizing people who didn't feel comfortable in that setting in the first place. So let's broaden our circles to clinics, okay? We're talking about how people feel, but now are clinics ready to hear about trauma? If you even talked about your own experiences? Well, what do we know about how health providers are trained? You, as well as I, both know that people are not trained to ask questions about sex, reproductive health, STIs very effectively so that they can ask those questions in an authentic way. People are not told that they can or need to ask about extensive histories of sexual abuse, physical abuse. Many people will use these terms, sexual abuse and physical abuse. We never use those in research. People don't know what we're talking about because sexual abuse to somebody might mean one thing and another to another. So we have to use very descriptive questions. Has someone ever put their penis in your vagina against your will, against when you were conscious or unconscious, or when you were asleep or unable to defend yourself? These are questions that are very graphic and are very offensive to some people who say, well, why do you have to talk like that? But because people have to know exactly what we're talking about. And for people who don't have a good sense of their bodies, we have to have anatomical charts. And the charts, we can show them. We're talking about this organ going into this vestibule in a woman's body, or this organ going into a male body. So that people know exactly what we're talking about. Some people don't know there are 3 orifices between a woman's legs, and that because they've never looked and they've never been taught. So of course, human sexuality training, in my view, is teaching people to look at their own bodies and identify exactly where everything is. And we do it with color-coded anatomical charts. Isn't that something? Color-coded. Why? Because everybody is not the same color. But if you're one color of brown, more or less your sexual organs are going to be the ones on the outside of your body, which we're talking about, are going to be color-coded too. They're not going to be pink like the pictures that you see in the public school books or in the medical school books. They're going to be, if you're brown, your penis will be brown, your vagina will be brown around the labia, and on and on. So we have to be very graphic about this because I want you to understand that we are missing something in our society. As sophisticated as we think we are, we're not at all inclusive in terms of making people feel that you're talking to them, okay? Other kinds of trauma like discrimination. I talked about that a little bit. So few in-service trainings are had, and in-service trainings really aren't enough. One and done is not enough to have a speaker come and talk about these things. Nobody's going to learn anything. They're just going to listen with interest and wonder, wow, you know, this person's doing this or that. But we want people to get comfortable about asking about trauma histories, how to record it in the files, to whom to report. They need to practice reporting. We're all mandated reporters, and yet people don't know what to say when they call certain numbers to report them. Some people who are asking those questions have histories themselves. Next slide, please. So are the staff prepared? Well, the question, of course, if the clinics aren't prepared, the staff can't be, right? Staff have to be trained on how to do all of this. They need debriefing sessions so that each week we have debriefing sessions on Monday morning at 9 o'clock. They're held by a psychologist, and we are asked about our experiences, collecting data, analyzing it, interviewing people, just dealing with COVID and what it's like, because we're doing all virtual research right now, but it's still highly traumatic to hear people talk about how they don't have enough food, they don't have enough water, and they're living in California. They're not living in Texas. They don't have the kind of PPEs that they need, masks, all kinds of things. And people have been expected to avoid infecting people without the adequate protection to themselves, and they're terrified. I haven't met one person yet who said, I can't wait to get infected with COVID. Maybe some naive people last summer did because they thought it was acting out and they were doing something against the will of their parents or authorities. But I don't hear many people talking about that today because they've seen people who are horribly ill with their lungs and their lives affected, and not just when the effects of COVID are at their height, but for many, many months later. This is nothing to sneeze at. And yet our society has been so terribly and poorly prepared, not just health providers and essential workers, but the general population has almost no information about these vaccines. And people wonder why individuals are suspicious about taking them. I just shared with you what healthy paranoia is. Well, it's alive and living today. And religious institutions are probably the least prepared to be able to talk about trauma and abuse. I can't tell you some of the stories that have been shared to me by people going to their ministers or their rabbis or their religious instructors to talk about what's going on in privacy of their homes and what people have been told to do. That's men and women. So we're doing a terrible job when it comes to preparing our staff to deal with the level of trauma that we are experiencing, and it's getting worse. Next slide, please. So now we know if you're dealing with HIV, and I hope some of you are, so you can really appreciate that, you know, some of the treatments have really made a significant impact on our ability to keep people alive, that people can live long periods of time. And that was so different in the early 80s when the first research projects that I had, people were preparing to die. So we had to have, as part of interventions, someone talking about wills and, you know, how to make preparations for death. We don't even do that anymore. People don't want to talk about death. They want to talk about living. And so we can say a lot about the treatments that have been developed in the United States and enjoyed around the world. But the treatment as prevention concept is one that I want to address right now. That is that people can take PrEP, which is it's a regimen having to do with certain kinds of antiretrovirals that if you take every day can reduce the chances of your getting infected. So in other words, you're taking a pill for something you don't have. You're HIV negative, but you don't have HIV, but you're taking the pill for it anyway. Now, this goes all the way from people getting no health care to people now who are taking medications for something they don't even have and usually don't want and don't even want to talk about. So we've come a long way in terms of our misunderstanding of the journey that we're taking people and what we expect them to do. So we've got some study, and this study just ended. Gilead Foundation funded a small study with HIV negative Black women at a HIV clinic in Los Angeles County. It's very popular. It's kind of run like a little village, very family oriented, very warm. People are very comfortable there. There's lots of food and merriment. There's not nearly any of that anymore because of COVID, but it certainly has resonated with a lot of people who don't feel very welcome in some of the other clinics where there are fewer people of color. But in our intervention, you know, we Gilead argued that Black women didn't really want to take these medications if they were HIV negative. And I said, well, you know, I think it's because you don't talk to Black women properly. First of all, in an HIV clinic, and this could be in many other kinds of clinics, well child clinics, they're not one-stop places in the community for people who may not have a car. So that if you're going there for your HIV treatment, for instance, there's nobody there that ever talked to a woman about her gynecological issues. She's treated what men get, women get. That just won't do. So we have clinics that offer STIs, reproductive health, and HIV services in one place. So the woman has to come into our project, get all that testing, and know exactly what her status is before she becomes a part of a 4-session intervention. And then at the end of that, we watch to see what she chooses to take. And what we found was that a lot of women had never even heard of PrEP. Number one. Number two, that there were some that were interested, but they needed more information and more time. And then we had to dig into why. The why has to do with their relationships with their partners. If you're talking to a woman about something, she has to go home and explain that to her partner about taking a pill every day. She's not taking a birth control pill, because some of those women wanted to get pregnant with their partner. So what is this pill? It obviously showed the need to involve partners in discussing what one person takes. The other person at least needs to know. But secondly, women needed more time to educate themselves, their partners, and to get some kind of regimen for how they were going to manage, which they did. It took more time than the clinics were prepared for, and it created problems in the sense that they didn't rush through. But that's the reality of some women. And I think it just showed that maybe we have a template for a rushed medical care that is not embraced by a lot of people who need time in a medical system. And the rushed effect just doesn't work. Next slide. Pardon me. So not everybody is ready at the same time. Now, women spontaneously disclose abuse. Pardon me. But the history and the whole process of asking about it, pardon me. You know, I think I need to get some tea. Hold on. Okay. We're teaching women now who are staff how to ask and be more patient with women who need to think about their care and come back on another visit. So now we've ended this study, and what we found was that women were very interested in, pardon me, different kinds of ways to protect themselves, but they had to make that decision on their own. Next slide, please. So now we're going to get into what you can do about all these things that I've thrown at you. As an individual, I think individual change is really very important. And I talked to a lot of people in community groups about what they can do aside from clinics, aside from our society. And that's why I wrote Stolen Women, about taking back your own individual life, taking responsibility for yourself and owning and claiming your own behavior. So this is something that I think everyone needs to ask themselves. Are you still a victim, or are you a survivor of oppression? Where are you a survivor, and where are you still a victim? All of us have something to do about being more empowered, about taking responsibility, about doing things that are going to be more proactive for our own individual health. And this is something that I like to begin with. But next slide, please. But I don't just leave it with the individual. There's a lot that we need to do about the research that we are conducting today. And this has not changed in my 47-year career. And that's the use of the term race or racial differences, how we describe different groups of people, why we are so wed to looking at the color of a person's skin to identify them in a particular racial group is intriguing. It's beyond concerning. It's intriguing that there is something that people cannot let go when it comes to how they're supposed to look at a person. And we know that these terms are misleading. I've written about it in the American Psychologist, talked about it, been on panels. It's really an issue that I would welcome you at the University of Maryland to talk about. The term race ethnicity is used now as kind of a mid category for people who won't let race go, but they really should be using ethnicity. But we really have a problem with calling things what they are, telling the truth, being accurate, and stop playing to people's need to feel superior. Next slide, please. There's one human race, and we all belong to it. And I, you can argue that all day, but that's just what it is. We've got science to back it up. What are we doing by using these terms and considering that this article is in a top-tier journal that still uses these terms? What's wrong? Why can't you see people in terms of their real differences instead of ones that are created in a white supremacist fashion? When you compare people and the rates between whites, blacks, and Latinx populations, it's just less meaningful. What does it mean that Black women are 3 or 4 or 10 or 12 times more likely to be infected than a white woman? Our experiences are also different, or between Black and Latinx populations. It's more meaningful to talk about within group comparisons when you have people who have like backgrounds, and then you watch and see where the change is in their life, than to look at someone who doesn't have that background and make a comparison. It seems to me to be confirming and enabling a supremacist kind of an ideology that some people say they want to change, but they're not changing it in research. Next slide, please. Some people are still using the term cultural competence, that they feel that they are competent as health providers because they work with people of color. I know in Baltimore, there's a huge population of African Americans around Johns Hopkins. There's a huge population of color in need, but people aren't culturally competent because they are working with the population. You have to know the historical healthcare utilization and service delivery issues. You have to know the values and beliefs and traditions and practices. And without that, then what are you really doing? What are you accomplishing? It's not competence. It's just working with a group. And it's important to work with different groups, but it's more important to really understand the group and the history and what people need to be working with. Remember the little saying that my mother used? You can use a stereotype and define a whole gender, without really understanding what a dastardly effect that can have on a little boy who might hear, all that you want to do is get in your pants. We're talking about a context, understanding the background, the history, all of the factors that make that person who they are. That's the kind of research that's going to help us to understand how to change behavior and eliminate anti-racist ideology. Next slide, please. there are many rules and laws and requirements, and this is really telling in this post-administration society about telling the truth, that are arbitrary even to African Americans today, because people have been claiming things were true that weren't true for so long. This is not new. And I think that some other people who believe, oh, politicians tell the truth. My mother told me, and my father told me when we were little, politicians don't tell the truth. So you have to know what the truth is so that you can call them on what they're saying and doing. We need a healthy skepticism that I think a lot of African Americans are raised with. It's called racial socialization, because it's important to know when you can trust and when you can believe and when you just can't. Next slide, please. So this is, I think I've already said this, that we really need to look at the journals. We need to look at the reviews of grants. We need to look at how we address differences amongst people and who's reinforced for what. We don't ding investigators who never talk about cultural beliefs and values, and yet that's the perceptions and the socialization that I talked about at the beginning of my talk. Those are values that everyone ought to understand and to know what to do with. Public health messages are important, but if they're in contradiction to culture, then you're going to miss a group of people. And yet those are individuals who sometimes are looked up to as the most esteemed when they talk about people as if they don't have a culture. We've just got to change that. Next slide, please. Who are the people doing the work with communities of color? Some of them will now, and this is kind of new in the last, 10 years, I'd say, maybe 12, 15, do the Lone Ranger approach of research, where they will send their assistants, their research assistants, into different communities and say that they are collecting data and relevant because their assistants are doing the data collection. But there's no design that has any kind of cultural context. There's no involvement of those assistants in any decision-making in the research. And the investigators are hiding behind their degrees or their university offices or walls. They're not accountable. There's no accountability for that research project. I was in South Africa. I'm an honorary professor, and I'm very honored to be at the University of Cape Town. But I was on a dissertation of a white South African woman who wanted to look at cortisol in the hair of African women. It's another way of measuring cortisol and stress. I don't approve of it, but I didn't come to that conclusion at the point when I started reviewing her dissertation. I came to it as a result of what she did. In her illustrations for women during the consent process, all of the pictures that she used were pictures of white women, and they showed their hair, and the little plug of hair that's taken out of the back of a woman's head had nothing to do with the women who were actually in the study. So women really didn't know what it looked like if their natural hair, a piece of it and a plug of it, was taken out. I don't think that should have been approved by human subjects. It was inconsistent with the reality that those women needed to know in order to agree or not agree. And so she had to do that part of her study over again. And it created quite a stir that an American woman, American Black woman to boot, had some issue with that dissertation. But if you're not there to do something about it, to inform and to speak out and to call out when you are there, what are you there for? There's no need to just mix in a group and all have tea. We need to get the research clear if we're going to really understand how to help people. Okay, next slide, please. I think we need to prioritize funding investigators who have a lived experience. There are far too few people of color who are principal investigators. I was just on an international call yesterday. The only person who was a principal investigator of color, of African descent, African American descent, on the phone. Where are the rest of the people getting these opportunities? There's something wrong when we've been in this business for this long a period of time and we've got research assistants and people can't get any higher than that. And this has been documented since the 80s. Black people don't get grants the same. They don't get grants with certain titles in the same way. The rates are different, and it hasn't improved. With all of this talk, there is something wrong with perhaps the focus on Black investigators and trying to help them. Maybe we need to be focusing on white investigators and what are they holding on to by denying Black investigators who may look at things differently, different topics, different designs, different methods differently. What do we have to lose? These are the people that they may be looking at in their research. They're the ones in need. Next slide, please. Do we really want science to progress or not? So communities have to be informed about what's going on. I think we need to have more town halls. Next slide, please. Culturally congruent research is what we should be advocating in my eyes. And that's when the research really is based on history. It's based on cultural values. It's based on beliefs. It's based on the things relevant to the population, not something that's been used in some other context and now is being used in another cultural context with very little adaptation or understanding that there needs to be. We need to teach our students how to critique manuscripts and write grants that are reflective of the experiences of those people that we need to address, or else we're simply taking one template and trying to make it work everywhere. Next slide, please. We need junior investigators who are actually going to replace us. And if they replace us while we're still working, then so be it. That means we've done a good job. That means we shouldn't be wed to being in charge of everything. Maybe we should be wed to mentoring. And that's where I am at this point. If you see most of the research that comes out of my team, I'm the last person. I am pushing. I may have been first on the grant, but I'm last on those publications if I'm on there at all. The issue is trying to give somebody else a chance to be first author, to be a part of the whole grant writing process. I bring them to meet people that I've met in Washington, met in private foundations. How will people get ahead if we don't really take mentoring very differently? And we need to realize that we've never seen a group of people who've had the kind of history that African Americans have change their behavior because whites wanted them to. FUBU, for us, by us. Change comes from within. That's where it should come from, because it's going to change and it's going to come the way that people feel safest in delivering change and then continuing because they realize that they will become more empowered when they change. Not because somebody used the same exterior control, which I've shown you, hasn't done us any good in the past, and it certainly isn't today. Next slide, please. This is a name of our very first intervention, Healing Our Women. It's been adapted. Well, it was in English and Spanish to begin with. It's been adapted for trans women and men who have sex with men. Now being used in the context of another intervention for cardiovascular health risk reduction and trauma risk reduction. So it just keeps growing. Next slide, please. You're welcome to have any of my materials. I want to encourage you to ask questions. I wanted you to know I met Martin Luther King when I was 16 years old at Fisk University. He inspired me. One of the things he told me when I told him I wanted to be a psychologist, only thing I've ever wanted to do was to reach back, and I've started my talk with that, but you have to keep going. Sometimes it seems like nothing's changing and everyone around you is staying the same and enjoying the sameness and the superiority of wherever they think they are, but things are going to change in ways that we can't even imagine tomorrow. This is a new world, it's a new normal, and we have to keep going. So if you can't do any of these things, just keep moving forward. This is going to be a part of a wonderful future for psychology, for public health, psychiatry, mental health, all medicine, all of these fields are going to be changed. They're going to be challenged, but they're going to change. And don't you want to be a part of it? Next slide, please. This is a stereotype of a downtrodden African American woman. She could be from anywhere, couldn't she? Who's tired because she works so hard. That's not my model. Next slide, please. Though I must say sometimes I felt that way. This is a beautiful picture of the stereotype of Black female sexuality. You all probably know these women. Tina Turner, who was for a time the prototype of Black female sexuality, and passed the mantle to Beyonce, who holds it. The only issue is, if this weren't the only thing we ever see is Black women with very few clothes on, maybe I wouldn't even bother to show you this slide. But if this is the only thing you see, and 400 years ago I could show you women who had on very few clothes, then I would tell you that we are not making any progress at all in terms of raising Black women up to a level where they actually are. And that is rightful individuals to be themselves, just like men should be, just like trans men and women should be, anyone should be accepted for who they are and not stereotyped because of the sexuality that was imposed on them. Next slide, please. This is my book. It's based on 20 years of experience, research experience that I wrote. It was a bestseller. I'm working on another one for the past 20 years from that point on. Let me tell you, it is an experience to be a part of a society that started when I was a little colored girl, because that's what I was considered, on my birth certificate in Fort Worth, Texas, to the point where I could have this opportunity at your beautiful university to speak about women, to speak about the dignity that I think that women and men deserve who are people of color. The richness of our society doesn't have a thing to do with the history of independence. It has a thing to do with the people in it. And we cannot minimize the richness of our diversity. It's who we are. It's why we are such a great nation. Next slide, please. This is my center. I wish I had time to introduce you to all of them. They are fabulous. They keep me going. I think I'm probably the oldest person on this team. Doesn't matter at all to me. It's not age. It's what you do with the life you're given. And I've had a good one. Next slide, please. Thank you. Thank you for listening. Thank you for inviting me to take this time. I hope there's some time left for you to ask me something. There's my email. Please send me something if you're not comfortable talking to me, but I hope you will talk to me now. Thank you.
Thank you so much for a powerful and important talk. I think you've given us so much to think about and so much for us to do to follow in your really inspiring footsteps. And I think you've laid out what our marching orders are to go forward. And I hope that you will have a whole crowd of us doing all of this great work as you've been doing. We've got a few questions that have already come in, and I want to encourage people to put more questions in the Q&A section. And Steve, Dr. Steve is going to take the questioning part of the presentation, read out the questions for you, Dr. Wyatt, so you can answer. Thank you.
I would also like to very much echo Anne's sentiments. Thank you. That was a very moving, very powerful talk. A lot of things to think about. I very much enjoyed it. I also would like to thank our attendees. I know it's very awkward to attend when it looks like you're the only person here. That's no, because if you, I've got some text from people. Why is there no one here? And I really would like to encourage questions. I do have one question from a graduate student, Shelter Desire, who's in our program. Yay! And Amy, I'm not sure if you would like to refer to the slide, but I did record the slide number. But Shelter writes, in the Gilead supported study,
yes,
the percent of women who had never heard of PrEP was reduced from 88 to 47% by the end of the 4-session intervention.
right.
And her question was, were these 47% part of the control group that didn't receive the intervention? Or, you know, if there's anything that you can elaborate on that, it would be greatly appreciated.
Well, what it demonstrated was that most of the women had not heard of PrEP. They were just blown away by the whole idea. And many, we cut that in half. It took 4 sessions to cut it in half. And we were talking about all different kinds of methods every session, but it still took 4 weeks just to get that cut in half. It seems to me that this is a concept, taking medicine when you don't need it, that is foreign to a people who didn't have any at all, and people who still save pills, share pills. And if you, for instance, start feeling better, you stop taking medicine because it's very expensive. And I know that African Americans aren't the only group that do this. Medicine is so expensive in the United States today. I think everybody shares pills that I've talked to, but even at work, they'll say, well, I've got this, in my purse, or if you don't feel well, come to my desk. What I'm saying is there's a great resistance to pill taking, medicines, that I think people don't appreciate. It takes time to get through these things. This is in an all-Black clinic with 2 Black facilitators, both trained, being treated extremely well. Every single time we saw them, we did everything to make them as sophisticated an individual as they could be. And we only halved it. So that means more work even needs to be done after just 4 weeks. That's not surprising, but I think for Gilead, it is.
Thank you very much. I actually had a question. It's incredibly important. I figure you probably know this and have done a lot more thinking with respect to prioritizing funding for investigators who have the lived experience within the community. That's absolutely appropriate. Do you have any like thoughts on models on how we can work with the funding agencies, on how we can figure out like grant review boards to think and prioritize this, to think more thoughtfully just about match the funding with the researcher?
Yeah.
It's the APA principle of, are you the right person to do this research?
Exactly. And we've talked about that, haven't we, in APA for decades. I think we all need to band together, Steve. I think we need to send group letters to NIH. This is a great opportunity because, whomever's going to head this whole system, and we're going to know pretty soon, in the next week or so, I think we'll know. This is a great opportunity for, I think, health professionals to make a statement that we don't want business as usual, that we have a crisis on our hands as exhibited by what's happening in COVID right now, that if we continue the way we are funding people and, and spending all this time reading these grants, and I've been on many of, study section and review every year because I have grants, I feel I need to give back, only to hear the same issues raised time after time. Well, this person doesn't really have a lot of experience. Well, this person, da, 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 da. I don't know about this. What measure is this? And I'm saying it's a measure that they have piloted on a group that maybe you don't know about. But does that mean they don't have a chance to do something different? How do we get ourselves out of this box, dictating that we're the only ones who should look at what the future of psychology is? It doesn't make a bit of sense to now have diverse students in graduate schools, which we're doing so more and more, only to hit a wall when they get out and they can't get funding. How can they get a job? How can they keep a job? How can they get on the tenure track? And I've mentored quite a few people, hundreds of people all over the world, never even seen some of them. They just email and say, look, I've never seen a Black psychologist. Could you just mentor me? Could you just look at my stuff? Could you just talk to me every now and then? And I do. How can I turn away? There's nobody else, should say, oh, no, could you call my friend, da-da-da? No, there's no da-da-da. Everyone's worn to a frazzle, trying to keep this mantle. I think we need to take action. And if you will help me, we can write a letter. We can all sign it. We just did this at UCLA about diversity within our faculty. We all wrote a beautiful letter. We sent it to the dean and the vice chancellor. And now we're getting some action. And I think we just have to use the power of who we are and our devotion to allowing ourselves to step aside and help someone else to take our places, or else 20 years will be gone and we'll be in the same boat, wondering why didn't so-and-so was such a bright student? Where'd they go anyway? You know, they didn't stay in your school. They didn't get a job.
Thank you.
Thank you.
I absolutely agree. I had a question I received in chat, and
Okay.
did you?
I was going to say, and there's a follow-up question from Shelter, but go ahead with the chat one, and then we'll get back.
My apologies. So this question is from Molly Franz, who's actually new faculty within the psychology department. Welcome, Molly.
Hey.
And so first off, she said, thank you so much for the incredible talk. It was incredibly engaging. I'm not going to tell you the tally of exclamation points. I'm reading, this is why I'm not seeing faces. I wanted to follow up on your point about not using the words race and ethnicity in research because it insinuates there is a biological component to race. You also described the importance of looking at within group race or within group differences. I have two questions. So one, would you recommend we completely move past looking at racial and ethnic differences in all circumstances? And I'll read the other one, and I guess you can decide which or how you want to answer. Do you have a recommendation for other words that you would use to replace the words race and ethnicity? And perhaps it's other constructs would also be another way to say, I'll mute myself. So
did you say that, Steve? Did you talk about concept?
I added the concept of rather than other words, why don't we think about these as constructs?
Yes, that's exactly what I would have said. You stole my thunder because we've got a critical vulnerability scale, and it's based on certain experiences that people say they have. That will flatten anything that has to do with race, because it has to do with the fact that people have histories of repeated victimization. They've been incarcerated. They have homeless histories. You know, they've just got a history of not fitting in anywhere. They're not working. They don't have cars. And in Los Angeles, that's a kiss of death. You can't do anything without some kind of transportation, or you're standing out on the street, you know, in the middle of the night. This is critical vulnerability. That's one construct. The other that Rosie Bingham, she's also very active with APA, came up with was deep poverty. These are folks that are like 2 and 3 and 4 standard deviations below what we in America call poverty. They're living off of like $200 to $300 a month. It's nothing, and yet they're living. You know, but in terms of knowing about resources and how to manage, they can survive, but by no means are they thriving. These are folks that are in and out of homeless shelters. So, you know, where's the permanence in their life? They don't own anything because things are constantly taken from them. Well, if you go back to that history, that was one of the huge domains of not owning anything because people owned you. So how then do you give a person an apartment if they've had that kind of history, and then they disappoint the officials because they can't keep the apartment clean? They've never owned anything. And so we don't even prepare vulnerable people for the experiences we'd like them to attain by having an intervention that would teach them the steps to ownership, in other words. We're not really addressing the things that people have missed in their lives, and we know how important these things are. But for us then to come in and give them an intervention on self-esteem or how to eat healthy when they will eat anything because they have to survive, it just doesn't make sense. You know, I'll leave it at that. You see what I mean? There's so much work to do in terms of helping us as the professionals to go to these communities and sit and live with people so we understand what they really need, and they will tell you what they need if you ask them.
While Steve is looking, maybe I will get back to the question for shelter, which is a great follow-up. And I'm looking at the time as well, and that might take us to the 5:30 hour here on the East Coast, and we should let you get back to the rest of your day there on the West Coast. So shelter's follow-up question was, what components do you think are necessary for culturally intentional intervention programs for CSA and SR survivors? And maybe you could define those two terms for folks who might not be as familiar.
CSA is child sexual abuse, and SR, I'm not sure what SR stands for.
That's a good question. Maybe shelter will write back in and help us, but maybe you could.
So the question is about what kind of intervention would be appropriate for them?
Yes, sorry, I just lost the, what components do you think are necessary for a culturally intentional intervention program? Yes.
Sexual re-victimization?
Oh, okay. All right. That's a really good question. It takes a whole bunch, but some of the concepts that I shared with you today, especially those 7 areas, domains, we have an intervention, the Healing Our Women one, and it's called Healing Our Women and Healing Our Men, that address each of them. So that, in other words, a person is learning, first of all, to have their abuse acknowledged. And sometimes the details of the abuse don't sound as credible as one would like. In other words, these are things that have happened a long time ago where it first started, and they're asked to talk about it if they want to. We'd like to confirm that that has happened, and to exhibit some kind of humanity in talking about how sorry I am that these experiences have happened to them, that I wish that I had been able to do more to help them when they needed help more. But now that they're talking about it, let's do what we can to try to help them now to understand how that experience is still affecting their lives. Because many people do not connect those things that have happened in the past with what's happening now. So that's one of the first light bulbs that goes on in a lot of people's lives that have had victimization experiences. And then we talk about why these things keep happening to them. What are the patterns that I showed you that have to do with lack of trust, really being very isolated, not knowing and having the skills to be able to learn how to negotiate and talk about one's body, not knowing what things they should be concerned about, not having any health care or any other kind of services to lean on, and they end up being victimized again. So we try to help them see that what's happened to them is not just a virtue, a nature, an artifact of their behavior, as it is their behavior in the context of a society that is not responsive to vulnerability, to traumatic experiences. And then we start to build them up. They have to write about their experiences each week. I'm looking at the time, I'm trying to hurry. And they do that by either talking into a tape recorder if they cannot write, but we will take a word. And you'd be amazed, one word a week by the end of the intervention, if the word is sorry or sad or scared, it's powerful, angry, and determined by the end. That's the growth that we try to help them build, to build a sense of who they are, and then how to protect it, how to love it, and then create a boundary around it. And that's the kind of intervention that that we do have. Whomever the young person is, I'm assuming they're young because I am so old. I would be happy to share our intervention if they want to see how we lay it out to get a sense of how you do it.
Thank you so very much for sharing your thoughts with us and sharing your time with us. You've been so generous.
My pleasure.
In coming to be with us. And I'm sorry we can't even offer you snacks afterwards or take you to dinner and nothing. We're terrible hosts. But it's been so nice, and I do hope that our paths will cross. And I'm sure on behalf of all of our participants, they hope to be able to see you in person one day. And thank you face to face for this great talk.
Thank you for your kindness. It's been a pleasure and a thrill.
Thank you very, very, very much.